So we're moving on now to a slightly noisy area, I guess I could say. Elyssia is an emergency physician, not a PEM, but a adult trained emergency physician, works in Ballarat, and also is, for her sins, doing a PhD on the management of the agitated adolescents, or mostly adolescents, children in emergency department, and is running a fantastic trial called Peachy, and she's going to give us a bit of an overview of the process. Thank you.
Thanks, Meredith. Yes, that's correct. I'm an adult emergency physician, but it's lovely to be here, and I work in Ballarat Regional Centre, so we look after quite a lot of young people there. I think most of us in this room probably have encountered or managed a young person such as this in their practice, and certainly they are common in the pre-hospital setting, the emergency department setting, and then also the inpatient setting as well. And I think they're very challenging and both pose, I guess, physical and psychological risk to themselves, but also us as healthcare professionals caring for them. And really today my aim is to provide a bit of an overview about this population or cohort, why some of these young people are becoming agitated or behaviourally disturbed, with the kind of emergency department focus or flavour, because I guess that's my lens. And also talk about, as Meredith alluded to, the Peachy trials and some of the other research which is emerging from my PhD. I should just put a little disclaimer though, kind of as Simon has alluded to, a lot of this area of medicine at the moment is quite evidence-free, so some of this is also emerging evidence or evidence from other clinicians as well. Before I go on though, I just wanted to frame this talk with this young woman. So this is Ashley Smith. Ashley was born in Canada and she was actually adopted at a very young age. She had a pretty uneventful upbringing until she was around probably 13 years of age or so. And at that stage, she just started to develop some behaviours of concern. She had significant school refusal. She had quite a few run-ins, just very small, but with the law or the legal system. And when she was 15 years of age, she was at home. She threw some crab apples at her local mailman. And because of that, she actually ended up being incarcerated within juvenile detention, which I think in itself is pretty shocking. She remained under the care of the juvenile justice system until she was 19 years of age. And during that time, she had a pretty tumultuous course, as you can see here. For the majority of that period of time, she was managed in seclusion. She was restrained, she was tasered, she was pepper sprayed, and shuffled around from prison to prison. And when she was 19 years of age, while she was still in the justice system, at this stage, because she had such prevalent and common episodes of behavioural disturbance, she was under 24/7 video surveillance with 2 guards watching her at all times. She self-asphyxiated in her cell and she died within the juvenile justice system in Canada. And I know that the juvenile justice system is very different compared to the healthcare system, but there are similarities. And the reason that I bring up this case is I think sometimes we forget when we're caring for these young people that behavioural disturbance, it truly is a medical emergency, but I think it doesn't get the same kind of kudos or weight applied to it as things like sepsis and trauma do. So I'm really grateful to the organisers for the opportunity to present this kind of work in progress, I guess you could say, today. I just firstly wanted to talk about some of the underlying causes or etiological factors that can contribute to behavioural disturbance in young people. By far the most common, and some of this was alluded to yesterday if you heard Yane's talk, is the kind of mental health disorders, and intimately linked to that is psychosocial factors. Whether that's that a psychosocial factor has contributed to the development of the young person's mental health disorder, or whether, which I think we see quite commonly in the ED, a young person with a mental health disorder who then has some kind of psychosocial factor that leads to them presenting to the emergency department in crisis. Neurodevelopmental disorders it's an interesting cohort of young people within this behavioural disturbance space, because from my kind of adult perspective, we don't see this group very commonly. But in this population of young people with behavioural disturbance, those with an underlying neurodevelopmental disorder, and what I'm really alluding to here is autism spectrum disorder and attention deficit hyperactivity disorder predominantly, really are quite a prevalent reason that young people may experience behavioural disturbance, and I'll speak more about that shortly. Substance use certainly is an increasing problem, especially in the later adolescent population, but it doesn't make up a very big piece of the pie in the young person kind of age group or bracket. And then organic illnesses, exceedingly rare, but I just bring those up because we always want to make sure that if the young person has something like meningoencephalitis or hypoglycemia, that we're detecting and treating that, because obviously very different management algorithm to what I'm going to speak about today. So just looking at mental health disorders in a little bit more detail, Danielle Assay, who's a Victorian paediatrician, did some work retrospectively looking at Royal Children's Hospital data, and she found that in the 2018 year, 7% of all presentations to the emergency department in that year were from a mental health condition, which is pretty common. Like, it's not quite 1 in 10 presentations, but it's a lot of young people presenting with a mental health disorder as their reason for presenting to the ED. And in that cohort, there was a large percentage that were related to acute severe behavioural disturbance, around 17%. And Harriet Hiscock, who's another Victorian emergency physician, Victorian paediatrician, also did some work looking at the way that mental health disorders are increasing in terms of their prevalence compared to physical health presentations. So herself and her colleagues looked at the Victorian Emergency Minimum data set and found that over a 7-year period from 2008 through to 2015, mental health disorders increased by 46% over that period of time, whilst physical health disorders only increased by 13%. So certainly we are seeing that mental health disorders are increasing kind of out of proportion to physical health presentations. This is probably familiar to most of you, but I just wanted to bring up these adverse childhood experiences, or ACEs, in the context or lens of a young person who has acute behavioural disturbance. And I think if you all think back to any young person that you have potentially seen in any setting who has behavioural disturbance, and then you look at these ACEs, most of the young people that we see, I would say, would have one or more of these factors. And that's really important because we know that ACEs contribute to physical and mental health problems later in life, and that the more ACEs, in particular 4 or more, a young person is exposed to, the worse their health outcomes are. So that's extremely important. But the other reason I think this is important is it certainly helps me, and I don't know, it may or may not help some of you when you're caring for these young people. Think about a cognitive lens of why sometimes these young people are behaviourally disturbed, and often, more challenging is not the right word, but I think they are often challenging to manage. And I know, me personally, I get a lot of counter-transference from these young people because I find that the way in which I manage them is slightly different, or needs to be slightly different, to young people who potentially don't have behavioural disturbance. And I think if you think about the fact that a lot of these young people might have been exposed to physical and emotional violence, and that perhaps the way in which they've seen conflict resolved within their home is physical and emotional violence, that when they present to the emergency department setting in crisis, it's actually not really a surprise that, because that's been their modelling, that's the way that they then attempt to resolve conflict. And that obviously plays out in a behaviourally disturbed state that we see in the ED. The other thing, and again, I know this whole talk's very confronting, so I apologise for that, but the other thing that I just wanted to mention is I think it's also really important to think about that for a smaller proportion, but an important proportion of these young people, some of them have been locked in their bedrooms or other places for long periods of time as a punitive or a punishment measure. And for a small proportion who potentially have been sexually assaulted, the perpetrator may have mechanically or physically restrained those young people. And if you think about the way we then manage these young people when they present to the emergency department, we use seclusion and physical and mechanical restraint as therapeutic type interventions. So you can imagine how distressing that would be for this cohort of young people. Just speaking about the neurodevelopmental disorders that I alluded to earlier, we have done some work looking at this cohort of young people with either ASD or ADHD within the acutely behaviourally disturbed cohort. And what we found was that when we looked at the overall cohort of young people presenting with, and this was retrospective work, a mental health condition, that young people with a diagnosis of either ASD, ADHD or both were grossly overrepresented when they were looked at in terms of the presentations with a mental health disorder. 28% of the total mental health presentation cohort had either one or both of these diagnoses, which is obviously grossly outweighs population prevalence. The other things that we found in that work were that these young people with either of those diagnoses were more likely to have a code grey or code black, so a security response. And in particular, young people with a diagnosis of autism spectrum disorder were 3 times more likely to be secluded, 3 times more likely to be restrained or receive medication. So certainly a population that requires further work. As every research talk, obviously more research is required, but a really important cohort within the young people who experience behavioural disturbance, especially in that ED setting. I just want to move on now and talk about some of the ways in which we can manage these young people. And I think most of us know, really all of the clinical practice guidelines obviously advocate for using the least restrictive means feasible to manage these young people, and I think that's appropriate. And that obviously starts with using non-drug-based strategies. The thing I would say here, though, is that I think this needs to be kind of a nuanced and personalised response to these young people and the young person in front of you. I think giving every young person who presents to the ED with behavioural disturbance a warm blanket is probably not going to result in them having their, behavioural containment. And I guess one thing that I really want to challenge all of you to think about here is, in this cohort, in all young people that we care for, but I think in this cohort in particular, it's really important to understand the profound power imbalance or dynamic that we have with our patients, whether that's the patient-nurse relationship or patient-doctor relationship. And I think it's subconsciously that we utilise that kind of power imbalance and the social norms to progress care or management for the patients that we see in the ED. And whether that's, even going and putting on the OBS machine, which we don't ask to do often, or if a young person asks us, can I do X, Y, and Z, say, they've got query appendicitis and they're fasting for an ultrasound, can I eat or drink? And you say, no, you can't. And you kind of expect within that setting, because you're the person who potentially has the power in that relationship, that they'll be like, you say no, and they're like, okay, that's fine. But this young group, I think, a young cohort of people are slightly different, and it kind of alludes back, I think, to some of those early childhood experiences that they've had, that potentially their modelling may have been different to the overall cohort. And another thing that I think is important is that boundary setting for this group of young people potentially may have either been non-existent, or they may have had boundaries used again in a kind of punitive fashion. So then when we try and set those boundaries or expectations within the emergency department setting, rather than them complying with our care, often that causes them to become profoundly emotionally dysregulated or escalated. So I would highly encourage you, if able, to consider this young group and give them a little bit more leeway if you can. Look, I might be a bit different in my regional ED, but say if they're like 17 years old and they want to go out for a smoke, I know it's not ideal, but I'm just saying that saying yes, that's fine is probably slightly less, it's more in fitting with that least restrictive practice when compared to them escalating and then having to use chemical restraint. We know, though, that even with that nuanced response, there is going to be a cohort of young people that are not going to be able to be behaviourally contained without medication. And whether that's because they've got acute psychosis, they might have, sympathomimetic toxicity, or there's a range of other factors that mean that medication might be needed for these young people. And I think I'll speak about oral medication a little bit more shortly, but I think that's the kind of least challenging as a health professional for us to use, because you offer the medication and then the young person's like, yep, no worries, I'm happy to take it, and you can still maintain your therapeutic relationship with that child. But parenteral medication is very challenging, because any young person that we're going to provide parenteral medication to, I would say, is pretty unlikely going to be willingly accepting that. And if they are willingly accepting that, I think you kind of need to rethink, should you be giving parenteral medication to this child? And I think that's really challenging. A lot of what we do in medicine as healthcare professionals is doing things without the overt consent of the young person or their parent guardian, like resuscitating a young person, for example. But this is slightly different, because it's not actually that you don't have consent. Often in this situation, for those of you that have given parenteral medication to one of these young people, it's almost anti-consent, because the young person often will be saying, no, don't hold me down, and I don't want medication, please don't jab me, I don't want that injection, which I think is really extremely confronting as a healthcare professional, and we should be confronted by that, because obviously you want to think twice about if you're using this medication in any cohort, whether that's adults or children, but I think it's a really tricky cohort to care for. And the reason that it's even trickier is because we don't really know what medications we should be giving to these young people. This is just a representation of what is currently recommended on the Australian guidelines by state. And you can see that there's a range of benzodiazepine and antipsychotic-based medications that have been recommended. And I've stolen this slide from Simon, thanks Simon. And the reason that there's such variability is because we don't have any evidence to tell us which medications we should be using in these young people. The parenteral medications that we're recommending have been extrapolated from adult evidence, so there's a lot of adult high-quality RCT-based evidence for parenteral medication in behavioural disturbed adults. And for the oral medications, even more interestingly, really there's no emergency department-based research to tell us which medications we should be using. That's predominantly been extrapolated from the inpatient psychiatric literature. And of course there is overlap, but there's also differences. So that really brings me to this, which is the studies that Meredith alluded to, the Peachy trials. So Peachy is a fancy acronym, don't need to remember, but it stands for Pharmacological Emergency Management of Agitation in Children and Young People. And the O stands for oral and the M stands for muscle, intramuscular. So because of this lack of evidence base and the vulnerability and importance of making sure that we're providing a medication if we need to, that's effective and has a tolerable side effect profile, these studies have been conceived. And really what we're trying to do in both of these studies is to determine across both routes in a young person who needs medication, so hasn't been able to be behaviourally de-escalated, which medication works more effectively to achieve successful sedation. And I'll speak about how we're determining successful sedation shortly. In Peachy O, we're comparing oral olanzapine and oral diazepam head-to-head, and in Peachy M, we're comparing IM olanzapine to IM droperidol head-to-head. And you might ask, why did we choose these medications? And there was a range of factors that were considered when we were deciding which medications to use. We have done unpublished at this stage, but has gone to publication, just waiting confirmation of that, a study across 27 Australian EDs to see if clinicians were managing these young people, what medications were they currently using in what cohorts, and what medications they'd like to see included. We've got a very large trial steering committee that I'll mention shortly, and then we also engaged a consumer steering group. So we had a number of parents who had had children in the emergency department with lived experience of behavioural disturbance or another mental health condition who helped us conceive these studies. And then we also engaged the child and adolescent psychiatrists, because obviously a reasonable large proportion of these young people will end up being admitted. So I alluded to successful sedation, and that's really what our primary outcome is to determine whether at 1 hour post-randomisation, which is at the time that we're reassessing these young people in the emergency department, whether they've achieved successful sedation. And we're using the sedation assessment tool score to measure that. So a score of 0, which is a calm or compliant child, or less meets the criteria for successful sedation. The reason that we've included without the requirement of additional medication is really for pragmatic reasons. You can imagine that a number of these young people will receive or need another medication whilst they're in the emergency department setting. And we wanted clinicians to be able to provide that if they needed to for safety reasons. But obviously it's just going to muddy the waters, and we won't know whether it's the trial medication or the additional medication that's been provided that has led to their sedation assessment tool score that's measured at the 1 hour time point. We're also going to look at adverse events and a number of other secondary outcomes in quite a deal of detail. I won't go into this, and it projects a bit better up there, but the long and short is if a young person is eligible, i.e. they meet all inclusion and exclusion and no exclusion criteria, they'll be enrolled and randomised to receive a single weight-based dose of olanzapine or diazepam if it's Peachy O, or olanzapine or droperidol if it's Peachy M, and then we'll have the primary outcome measured at 1 hour post-randomisation, as I alluded to. So where are we currently up to with these studies? You can see that the studies are running across 7 sites, and these are open label, obviously multi-centre randomised controlled trials, and they're both actually using a waiver of consent. These 7 sites so far, we've managed to recruit 77 patients out of a total 348, which is our sample size for Peachy O, and a total of 24 so far for Peachy M. Obviously, we've still got a way to go yet, and I'm hopeful that we will be hopefully able to finish the studies in the next couple of years, and I'll just update you shortly as to how you can follow on with the results or further information about the trials if you'd like. Similar to both Simon and Donna, I just wanted to mention there's obviously a huge range of people that have contributed to these studies. The 4 people highlighted in orange are both my PhD supervisors and members of the Peachy Trial Steering Committee, and the other members mentioned there are members of the Peachy TSC. Obviously, huge thanks to Predict and the Melbourne Children's Trial Centre. We've got a range of funding which has made this possible and also my PhD possible, so I'm extremely grateful to them and to that funding so that we could do these trials. And this is my only plug, I promise. We have a Twitter account, PeachyRCT, and we have about 6 followers, one of whom is me following the study account. So if anyone would like to follow us on Twitter, please do, and I'll try and keep that updated. And I'm certainly happy to take any questions by email at any stage if you don't want to ask them today about PhD or Peachy or other. So thanks very much.
Thank you so much, Elyssia. It's great to get that overview. It's a bit scary stuff. But has anyone got any questions for Elyssia and her Peachy studies or managing? We've had a bit about adolescents during the meeting. Oh, sorry, Andy, go.
Elyssia, are you collecting data on the first language spoken by these children and or their parents?
We're actually not, Andy, to be honest with you, and because it's quite challenging because of the waiver of consent, we can enrol young people who potentially are from a background that means that they're non-English speaking. So it's actually not something that we are collecting. It probably is something that would be useful to collect, but no, it's not something that's included currently.
Next amendment coming up.
Yeah. Next protocol amendment.
Any other questions? Oh, Andy.
I've got one more. One of the challenges we have in my state, Victoria, is actually what do we do with these patients afterwards? And they're going to stay in my emergency department for 3 days. It's great being able to control their behaviour in that very small setting, but what do we do after that time?
I think that is really challenging, Andy, and we certainly are collecting information about, we are going to do a health economic analysis from this work because I think they are a group that are very challenging in terms of exactly as you say, disposition. I think in particular, and this was kind of alluded to yesterday a little bit in the session around like the mind and body topics as well, that it is challenging, especially if they have an underlying neurodevelopmental disorder and intellectual disability. Then it's a question of who is the best team to look after these young people and who is the right team for now. And I think there is a lot of back and forwards around that management. And I don't have a good answer for you around that, but we obviously, I mean, I'm in Victoria too, but certainly there is similar challenges and we don't have a child and adolescent unit where we are. So that is something that's very challenging. I'm hoping that at least this work will be able to provide some information about the length of stay of these young people, and we will get information about their background demographics. So it certainly won't be anything that will be statistically significant, but just in terms of demographics and which groups of young people are staying longer and potentially why, I think will be useful. But yeah, it's very challenging, extremely challenging.
Well, I'd like to thank everyone who has just followed Peachy. 61 Yay! Followers now.
Oh, so I reckon we might have had it more than 6, but thanks everyone. That's great. Thank you.
Are there any other questions before I wrap up?